Hi, I'm Jocelyn Compton, and let's get started on ethical principles. These topics are less concrete than other topics, but test your understanding of ethical and social aspects of medicine. These questions often appear as quotations and ask you to choose what should you say to the patient? An answer that is empathetic, open ended, and non judgmental is usually the correct one. Alright, let's go with some specifics. There are four core principles in medical ethics: autonomy, beneficence, non maleficence, and justice. So, what is autonomy? Autonomy is the obligation to respect patients as individuals and to honor their preferences in medical care. This also applies to patients refusing care. A patient who is competent and over 18 has the right to refuse treatment at any time. Beneficence is the notion that physicians have a special ethical duty to act in the patient's best interest. Does this conflict with autonomy sometimes? You bet. If the patient can make an informed decision, then ultimately they have the right to decide. Autonomy totally trumps beneficence. Non maleficence is simply the physician's obligation to do no harm. However, in situations where the benefits of an intervention outweigh the risks, a patient may make an informed decision to proceed with the intervention, even if there's a chance that the intervention may result in harm. Can you think of a situation where the benefits and risks are routinely weighed against each other? Well, this is the case for most surgeries, and even medications. Finally, justice is the physician's ethical obligation to treat all persons fairly. Informed consent is a straightforward medical legal principle and requires three separate conditions to be met. First, there must be a discussion of the pertinent information with the patient. Second, the patient must agree to the plan of care, which means they have capacity, or the ability to reason and make their own decisions. Third, the patient must be free from coercion, and thus they are acting voluntarily. Essentially, informed consent requires that the patient understand the risks, benefits, and alternatives of a decision, which includes no intervention. On the exam, exceptions to informed consent are more likely to be tested than informed consent itself. If the patient lacks decision-making capacity or is legally incompetent, then there is no requirement for informed consent. If the doctor then decides to care for the patient, then he is exercising which core principle? Beneficence. Similarly, there is always implied consent in a medical emergency. Also, withholding information when full disclosure would severely harm the patient or undermine informed decision-making capacity can be an exception to informed consent. This is called therapeutic privilege. An example may be a depressed, suicidal patient who has a new diagnosis of terminal cancer. Since this is a controversial topic in clinical practice, you can be pretty confident that invoking therapeutic privilege on the boards would probably be the wrong answer. Depression and suicide will also be discussed in more detail in the psychiatry chapter. Finally, patients may always explicitly waive their right to informed consent. Informed consent can also show up in disguise on the boards. For example, when a blunt force trauma patient comes into the ER, a question may ask your next step: go to the OR or resuscitate the patient to obtain informed consent. This is important because the question is actually asking you if the presentation is emergent, and so consent would be implied. Go to the OR. Consent for minors is a tricky issue, and it's commonly tested. First, who's a minor? A minor is any person that is less than 18 years of age. Parental consent must be obtained unless the minor is emancipated. Emancipation occurs when the minor is married, is self-supporting, or is in the military. In some states, even if a minor has a child, they may not recognize the individual as emancipated. Thus, this person would require parental consent for any procedure. However, parental consent is not required for emergency situations, contraceptives, treatment of STDs, medical care during pregnancy, and management of drug addiction. One way to remember this is to think of sex, drugs, and rock and roll. It's also worth knowing that parents, even if they are competent to refuse their own treatment, cannot refuse treatment for their children in life or death situations. One way the boards may test this is by giving you an emergency room clinical scenario where the parent is refusing treatment. The first step is to decide if the scenario is indeed an emergency. If the scenario is not life-threatening, then you should choose the answer that respects the parent's decision or delays medical decision, such as monitoring the patient. You should also be on the lookout for an answer choice that encourages healthy communication between the parent guardian and the patient. Decision-making capacity requires 5 conditions to be met. First, patient has to be able to communicate a choice. Second, the patient has to be fully informed. Third, the patient's decision must remain stable over time. Fourth, the patient's decision must be consistent with their values and goals. This may require consultation with someone who has a long-term relationship with this person. Fifth, the decision must not be the result of delusions or hallucinations. Also, it's worth remembering in these types of questions that a patient's family cannot require that a doctor withhold information from the patient. Again, there shouldn't be any reason to invoke therapeutic privilege on the test. Can you think of a common situation in which a patient would temporarily not have medical decision-making capacity? Being drunk is pretty much the equivalent to being incapacitated, and thus, intoxicated patients that show up in the ER do not have medical decision-making capacity. It's time for a flash quiz. How can a minor become emancipated? If the person is less than 18, but they are engaged, self-supporting, or are in the military. What's an advance directive? Advance directives are defined as instructions given by a patient in anticipation of the need for a medical decision. These statements, oral or written, champion patient autonomy by allowing the patient's wishes to be carried out. An oral advance directive is an incapacitated patient's prior oral statement commonly used as a guide to their wishes. If the patient was informed, the directive was specific, and the patient made a specific choice, and the decision was repeated over time, then the oral directive is more valid. However, if any of these conditions do not hold, then problems can easily arise from differences in the interpretation of the directive. A living will is also called a written advance directive. Here the patient describes treatments he or she wishes to receive or to not receive if he or she becomes incapacitated, or if the person cannot communicate treatment decisions. In most cases, the patient will direct the physician to withhold or withdraw life-sustaining treatment if he or she develops a terminal disease or enters a persistent vegetative state. Finally, medical power of attorney is when a patient designates a surrogate to make medical decisions in the event that he or she loses decision-making capacity. In this context, the patient may also specify decisions in certain clinical situations, similar to a living will. The surrogate retains power unless revoked by the patient, making this more flexible than a living will. If an incompetent patient has not prepared an advance directive, individuals who know the patient, called surrogates, must determine what the patient would have done if he or she were competent. The priority order of surrogates is the spouse, then adult children, followed by parents, adult siblings, followed by other relatives. Can you see the major problems that doctors get into with this hierarchy? There's no provision for which adult child should be given decision-making responsibility, nor is there a provision for significant others who are not spouses. Confidentiality means that you must respect the patient's privacy and autonomy and cannot reveal any medical information you learned while treating the patient. How would you approach disclosing information to a patient's family and friends? Always remember that disclosing information to family and friends should be guided by what the patient would want. Also, the patient may waive the right to confidentiality, which often occurs with insurance companies. Again, for the purposes of the boards, it's more important to know about the exceptions to confidentiality as opposed to confidentiality itself. If the potential harm to others is serious, or if the likelihood of harm to self is great, then the patient's right to confidentiality is no longer valid. This encompasses threats of homicide or suicide. Moreover, if no alternative means exist to warn or protect those who are at risk, then a patient's right to confidentiality is no longer valid either. In these situations, you may be required to take steps to prevent harm to the patient or to others. Can you think of some examples in which these exceptions would come into play? These exceptions would be especially relevant for certain infectious diseases, where the physicians may have a duty to warn public officials and identifiable people at risk. Also, in cases of child or elder abuse, impaired automobile drivers, and suicidal or homicidal patients. These exceptions definitely apply. One important Supreme Court decision that you should know about is the Tarasoff decision. This decision set the precedent for the physician to directly inform and protect a potential victim from harm. The board loves to present questions concerning ethical decision making. This is extremely high yield to review, but given the number of situations that could be presented, it's very difficult to cover every possible ethical dilemma that you could be presented. To review this material, it's probably best to understand a few general principles and apply them to diverse situations that might arise. So in general, going to a superior, a court, or to the ethics committee is just not going to be the correct answer. Furthermore, should you ever refer a patient to another physician? No, almost never, regardless of the situation presented. When given the answer choice to refer the patient to someone else, there's always going to be a better answer choice listed because the test makers believe that the original physician, this guy, should handle all ethical situations, and referrals are unnecessary and, quite frankly, unprofessional. Learn this fact for the boards and then totally forget it for the wards. Patients' wishes and comfort come first, superseding orders of a superior. Competent patients have the right to refuse procedures, treatments, and disclosure of information. Finally, getting enough information and asking open-ended questions before taking any action is a good rule to remember for the USMLE. Let's go through some examples now. What should you do if a patient is not adherent to treatment? The best response is to try to identify the patient's reason for noncompliance and determine their willingness to change their behavior. Do not refer this patient to another physician. As an example of patient non-adherence, if a patient continues to smoke, even after repeated counseling sessions, the appropriate response is to ask the patient how they feel about smoking, and to offer advice on cessation if they express an interest in quitting. The appropriate response is to ask the patient how they feel about smoking, and offer advice on cessation if they express an interest in quitting. What about medication noncompliance? If a patient is having difficulty taking their medication, the appropriate response is to provide written instructions and attempt to simplify the treatment regimen. Another very common scenario is when family members ask for information regarding a patient's prognosis. What ethical principle would this violate? Patient confidentiality. The appropriate response here is to just avoid discussing these issues with relatives without the explicit permission of the patient. However, don't choose an answer that seems rude or off-putting. What if a child wishes to know more about his illness? The appropriate response is to ask the parents what they have told the child about the illness because the parents of the child decide what information can be relayed. Pregnancy is another high-yield ethical situation to review. If a minor is pregnant and requests an abortion, the appropriate action is to not advise the patient to have an abortion regardless of her age or the condition of her fetus unless she is at medical risk. Also remember that many states require parental notification or consent for minors to have an abortion. Another scenario is that a minor is pregnant and wants to keep the child, but the parents want her to give it up for adoption. The correct action to take here is to provide information to the patient about the practical issues of caring for a baby and discuss the options with her if they're requested. Also, you should really encourage open communication and discussion between the teenager and her parents to reach the best decision together. The key here is to remember that the patient always retains the right to make decisions regarding her child, even if her parents disagree. Thus, parents can never force her to give her child up for adoption. Another topic to review is suicide. If a terminally ill patient requests assistance in ending his life, you must always refuse involvement for the purposes of the boards. However, physicians can prescribe medically appropriate analgesics for pain control, even if it happens to shorten a patient's life. How do you think you would approach an interaction with a patient who is suicidal? If a patient is suicidal, then you must assess the seriousness of the threat and suggest that the patient remain in the hospital on a voluntary basis. Remember, in these situations, the patient can be hospitalized involuntarily if he or she refuses to be admitted, because the patient is deemed to lack decision making capacity. In scenarios where the patient states that he or she finds you attractive, romantic relationships with patients are never, ever appropriate. Never tell the patient that there can be no relationship while he or she is a patient, because it kind of implies that a relationship would be possible if the individual is no longer the patient. In these situations, ask direct, close ended questions and use a chaperone if you need one. If the patient ever states that they feel ugly, find out why the patient feels this way. But don't offer false, reassuring statements like, "You still look good." These are trap answer choices, and they're always going to be incorrect. The appropriate way to respond to a patient who is angry about the amount of time that they've spent in the waiting room is to acknowledge the patient's anger, but don't take it personally. You should apologize for the inconvenience, but you should also stay away from any kind of efforts to explain yourself. What if the patient is upset with the way he was treated by another doctor? The appropriate response is to suggest that the patient speak directly to that physician regarding his concerns. If the problem is with a member of your office staff, tell the patient that you'll speak to the individual yourself. What happens in the event of a medical error? Regardless of how serious or trivial the error is, the physician is ethically obligated to inform the patient that a mistake has been made. If a patient requires a treatment that is not covered by his insurance, you should never limit or deny care because of the expense in time or money. Discuss all of the treatment options with patients, even if some are not covered by their insurance companies. Let's have a flash quiz. Patient's daughter approaches you in the hallway outside the hospital room. She's crying. She asks you, please don't tell my father anything about his diagnosis. Please don't distress him. What should you do? You should ask the daughter further about her concerns and find out why she wishes the diagnosis to be withheld. Never be rude, brusque, or dismissive, but also don't agree to withhold information. You may offer to discuss this with the patient and the patient's family members all together. Address the family members' concerns and gracefully explain your obligation as a physician to the patient.